Hi, all. Thank you. I want to thank BioDiscovery and BioNano for allowing us to present our work on NGS homologous recombination deficiency. My name is Chris Lum. I'm the Medical Director of Molecular Diagnostics at Diagnostic Laboratory Services in Honolulu, Hawaii. And with me today is Zan Halford. Zan, can you introduce yourself?
Hi all, my name is Zan and I am a technologist and I've been closely working with Dr. Lum for 8 years now, and we have been quite a paired set of colleagues for next-gen sequencing and expanding on that in the island and the state of Hawaii. So it's good to be here.
Thank you. And so I'd like to present, we're excited to present our work on NGS homologous recombination deficiency, particularly in the sense of expanding NGS capability to look at larger structural, genomic, or chromosomal alterations. Our goals today would be to describe homologous recombination deficiency as a way it is infected by DNA damage and its role in cancer therapy. And we'll be particularly focusing on high-grade serous ovarian cancers. We'd also like to summarize the method of software evaluation, because this is a bioinformatic challenge to be able to take NGS data and look at these things beyond that. And lastly, we'll describe some of the performance of this NGS solution to look at this genomic alterations, and describe some of the performance and limitations of using NGS data to look at these changes. So where does the story begin? The story begins with how our cells handle DNA damage. And there are a number of ways. And this is a graphic that shows some of those. First, there are single-strand DNA damage repair mechanisms. The first is base excision repair, looking at altered or damaged nucleotides. The next is nucleotide excision repair, where chemical alterations of nucleotides can be edited. And the last in this category is mismatch repair, or where bases are misassociated. But the more significant damage to our chromosome happens with double-stranded breaks. And in that category, there are primarily two mechanisms in which those are handled. The first is one that is prone with error, called non-homologous end joining, where it is randomly associated with the other, with a pair of DNA close by. And this can often lead to error as well as translocation. A far more elegant approach to DNA double-stranded damage is homologous recombination repair, in which the sister chromatid is used as a template for that repair. When cells have an alteration in that ability to have homologous recombination, that's called homologous recombination deficiency, or HRD. And there are a number of mechanisms which can cause homologous recombination deficiency. The one that is primarily highlighted is BRCA1 and 2 mutations, and that is known for decades now. But there are other mechanisms that can cause a homologous recombination deficiency that prevents a cell from repairing these types of defects. Some of them are somatic. Some of them are not BRCA1 and 2, but are part of other genes that are involved in this type of repair. BARD1, PALB2, for example, RAD51C. There are also epigenetic causes that also affect homologous recombination deficiency. And when we are in a state of HRD, it affects the way in which our cells have the ability to repair double-stranded DNA breaks, and it promotes a state of genomic instability. This genomic instability can now be leveraged for cancer therapy. So how do we look at HRD status? Well, we could look at, and in the past, we looked at simple germline mutations. Maybe if we just did NGS to look at SNP and indel changes in germline mutations for these genes that are involved in HRD, that would be one way of looking at it. The next is somatic alterations, that maybe genes that have been altered on a tumor-based level can have ability to affect HRD. That is another way to look at it. But the more comprehensive way of looking at HRD looks more at the outcome of all of the different things that cause homologous recombination deficiency and looking at the effects of what that are, meaning that we look at genomic instability. And by doing that, we look at genomic scars. And in looking at genomic scars, we look at three parameters: loss of heterozygosity, telomeric allelic imbalances, and large-scale state transitions. And that's shown in the purple boxes. And so why do we do this? Well, we're trying to promote an idea of synthetic lethality, or where a cell is able to repair double-stranded DNA breaks by the genes that it has to repair, and it uses an enzyme called PARP. And when those two mechanisms are working okay, the cell is able to carry on with repair and carry on with living. If one of those genes were to be altered, BRCA or BRCA-associated genes, PARP is still able to step in and repair double-stranded DNA breaks. And if a cell were to have defective or inhibited PARP, those BRCA genes will also be able to continue repairing DNA breaks. But when a cell has a mutation in BRCA or a mutation in BRCA-associated genes, and we also are able to block that PARP enzyme, that is an ability now to cause cell death, and that's synthetic lethality. It was leveraging alterations in BRCA and BRCA-associated genes such that we can cause cell death by making the cancer cells unstable for life, continued growth. And so this is a perfect case for ovarian serous cancers. Epithelial ovarian tumors have demonstrated significant sensitivity to PARP, or poly-ADP ribose polymerase. And some of the PARP inhibitors that have been used in this field are olaparib, who has original indications for BRCA-associated cancers. And that has now been assigned to all lines of therapy for ovarian cancer, both frontline, switch, maintenance, and also recurrence. There are other players that are part of PARP inhibitors, niraparib and rucaparib. And so if you look at the ovarian cancer landscape with regards to HRD, it is not just involving BRCA1 and 2, but it also involves other genes, RAD51C, also amplifications like cyclin E1, MZ, and also losses like P10. So just looking at single nucleotide changes, indels, and copy number changes isn't able to solve all of the ability to detect HRD. In particular, if you look at this area right here, which I can't point to, for BRCA1 and 2 promoter methylation, epigenetics is also a method in which HRD states can be achieved that can't be detected by standard NGS platforms. And what we're trying to do is enhance standard of care for ovarian cancers. So the standard of therapy for ovarian serous cancers are surgical debulking and followed by platinum and taxane-based chemotherapy. And that puts patients, about 75% of patients, into remission. But about only 30% of them will be cured. And when those other patients, the other 70% that have recurrence, those tend to be chemo-resistant. And so this is a perfect situation to now look for molecularly targeted therapeutics to handle those patients that are not sensitive to standard chemotherapy. And this is where the assessment of HRD comes in. So we can look for germline alterations and we can look for somatic alterations, but we really need to be able to look for the HRD states to find the indications to now use homologous recombination deficiency to justify the use of PARP inhibitors. PARP inhibitors are also being looked at now, not just for ovarian serous cancers, but for other cancers like ovarian, prostate, pancreatic, and breast cancer. So for institutions that are running NGS platforms, having an ability to use HRD or NGS data to assess HRD and genomic instability really enhances your ability to provide the full spectrum of biomarker targets for your oncologists and surgical oncologists. And I want to pass it over control to Zan to show how we can use that NGS data to assess HRD.
Thank you, Dr. Lum. So our next set of slides is going to discuss how we are leveraging summarizing software and leveraging what we can use as far as moving away from a traditional array methodology to using next generation sequencing, massive parallel sequencing here. In summarizing the pie chart of how DNA can be damaged, the assays that you see here kind of tier through getting to opening up to larger evaluations of the genome and its instability. You can see in the blue box, the DNA damage response and repair gene alterations are certainly sought after, as well as the homologous recombination repair genes here. And you can see where we have assays leveraging those. They're also now leveraging, whereas down in the red, we see the genomic scar types present. These assays out here in the commercial space have our next generation sequencing assays, and they both have two different approaches. You can see one is selecting for a genome-wide loss of heterozygosity evaluation. Basically reported as a percentage. And another has a larger box of surveying loss of heterozygosity, LOH, telomeric allelic imbalance, TAI, and large state transitions or scale transitions, LSTs. We call that the genomic instability score. And we are going to reference that and percent LOH as we move through how our in-house validation compares to both. This next slide is really the process of a commercial lab's effort as well as our own to try and do what we can with leveraging all of the literature out there assessing each of these states. Collectively, as we aggregate what they do evaluate, and this is a data evaluation of being able to visualize that they are happening in the tumor, it is that more data is better data. So the aggregation of all of the states seem to have a better predictive response than just evaluating one. So I want to now kind of break open just to define what each of these states are. On the left is a nice diagram of different ways that you can see the loss of heterozygosity, which is where a represented parental allele has been deleted. With respect to the literature, what we're looking for is where that is occurring over a span of 15 megabases, but also shorter than the whole chromosome. The telomeric allelic imbalance is similar. There is a there's a loss of representation of a parental allele or an imbalance depending on the type of copy number change, whether it's gained or lost. And with respect to the literature, again, we, as you see down below cited in the coming slides, we need to evaluate these at a size greater than 10 megabases. And finally, with the large scale state transitions, LSTs, what these are events of instability that are greater than 10 megabases. What we distill from this is we are actually counting the 2 breakpoints that homologous repair deficiency shows us, where the cell cannot repair its double-stranded breaks. So when we refer to LSTs, we're often just trying to discuss the number of times we see state changes and thus the breaking of a DNA to then become abnormally represented, whether in the allele frequency or the copy number. You can see that we do want to exclude centromeric areas as telomeres also. As for those, centromeres are in the center and the telomeres are at the very end of basically the chromosomal arms. So we have to be respectful to it. There's ambiguity as to why certain things during mitosis and meiosis may actually co-occur. And so we rule those out in our scoring calculation. And then lastly, we do want to make sure that when LSTs are close together, such as there's a microsection between 2 state changes, there needs to be at least 3 megabases of genetic material that's in a similar state in order to count really close breakpoints together. As you see, when we want to find the sum of the GIS, the genomic instability, and in our sense, we call the HRD scoring, we need to add up all of these together and basically also to assess them as they are now aggregating together. With respect to Biodiscovery's NX clinical software, that X is so small. We have in the title there, and we have this display here to show you that through some permutations, we've now maintained that you can have overlap of both telomeric allelic imbalance as well as a loss of heterozygosity present. Also to the right, you can have shared LST changes. And as we said, we need to distill to the breakpoints. So in sharing this, it changes a way that we evaluate what is present. Or I shouldn't say it changes. I should clarify that in evaluating it, we can both have 2 things co-occurring and so evaluate that both things are co-occurring. Here is a table of how the NX clinical software that we're using and displaying today classifies what it sees. And as we are now getting towards how do you add up what is present as a scar and assign it an integer of weight, we look at this table to show that every X here will gain a presence integer, an integer of 1. And the LSTs that are present will be counted as they're present and excluded if they need to be, and counted once if they're shared, like in the former slide you saw can happen. So as we look in towards on the right side where the green section is sorting out the integers, whereas on the left you see sort of the many iterations or permutations that the scar classifications can exist. This is refined now, and is a part of what they offer as an automatic calculation for us. As far as being in development with them, it has really been a great leg up on understanding the ways that all of these scars can coexist. So here is a tumor sample presented to you, one of ours. In the software, it would be fortuitous to do this. Obviously, most do, and they show you an ideogram of the genome. So if we look for a minute at this, you can see that there's red and blue, which discuss a gain in blue and a red loss state change across the P and Q arms of each of these chromosomes. You can now also see down in the lower left, there are the 3 genomic scar classifications present in the legend as purple, yellow, and black. So if you look at chromosome 2, you can see that we're having the shared event of a TAI LOH present here, simply because of the ideogram showing you overlap. So it happens, and quite often it is an unstable genome looks like this. So I'm going to take us through quickly the calculations of each of these events. For the loss of heterozygosity ideogram here, you can see that the data is classifying that a greater than 15 megabase copy number loss event is happening. You can see the data visualized here, that there are a state change involving 2 different breakpoints in the interstitial area. So we have an HRD LOH and 2 breakpoints happening here. In other examples, we have in this a Q arm loss, and this is classified as an HRD loss, but we have to exclude the 2 breakpoints, being that they land in the centromere and the telomeric regions. So for these 2 examples, our scoring here is shown. We have the integer of the presence. It's the integer of 1 or 0. So we have, on the left, we have an HRD LOH present, as well as on the right. However, the left differs because of the 2 breakpoints, and the right does not have any that we can include. So you can add 1 and 2 is 3, and that is what that simple event is adding to the overall assessment of each genome. We go scar by scar, and in the end, we have total score represented. So we've got 2 more. We have the telomeric allelic imbalance next to cover. This is any gain, loss, or allelic loss of heterozygosity that extends to the subtelomere, but does not cross into the centromere. And it must at least be greater than 10 megabases. So I am showing here a telomeric allelic imbalance. It is also the overlap of a loss of heterozygosity. So it's one of those ones that fits TAI LOH in the middle of the Venn diagram that we showed earlier. You see the telomere involved on the rightmost side of the zoom in of the Q arm, and then you also see where the state change of the LST had occurred. So with the summation of this event, we need to look at, do we see the loss of heterozygosity, the LOH classification present? We do. And do we see the telomeric allelic imbalance scar classification present? We also do. NX Clinical has made that TAI LOH its own. It is the pink classification visual there right under the chromosome ideogram. I add that that's here, and that's helpful because it does train your eyes to understand. You can have the software help you color code that. It's frankly a great way to learn. And sorry for the tangent. Now, we also finally do see that in order for that to have happened, you needed the state change, of course. That is the LST break. That's also present at the point where the copy number track shows that there is a loss of content. So in total, this sums up 3 points towards the total genomic instability score. Finally, you have seen, as we've gone through, that without any of the former two, the state change has to happen for any of the former two events we were just speaking of to happen. So he's kind of a mutual evaluation at that time, but I'm just going to ask us real quickly to focus on looking at the breakpoints themselves and how that they can co-occur. So on the left, you see, these are two examples of basically showing you the types of LSTs you may see. You may see co-events occurring to classify, like on the right. And this is something that NX Clinical has worked very hard to evaluate and allow automatic scoring towards. And it's a really bright new future to be able to evaluate these much more quickly than formerly in a manual sense. So I must commend them for working very hard to do that. I see that on the left, we're going to focus on this one first. And what you see here is the 2 breakpoints and the classification of the HRD LOH. We've seen this slide before, as well as this on the right. We see that there is a gain, and there's also a secondary zygotic event happening. So this one is a situation of evaluating what's here. We see a set of breakpoints, and we also see the gain end at the centromere. So by excluding the centromeric involvement and calculating the 2 breakpoints that we see present, this gives us 2 in total. I am now going to pass it back to Dr. Lum to speak on our studies and comparing the percent LOH and the genomic instability score, and finally rounding out with how chemotherapy response scores may or may not be concordant with evaluating PARP on its own for potentially changing the way that we approach when we should do HRD testing.
So how did we do? Using Zan's and our HRD scoring technique, we wanted to see how we compared to other laboratories that were assessing HRD. And the first was percent LOH. And what we did was we took a small series of cases that were run by outside laboratories looking at percent LOH, and it was a range of different tumor types, both ovarian, pancreas, breast, prostate. And these are other cancers that have the potential for PARP inhibitor indication. And what you can see is that it had a not encouraging sensitivity, And there were some discrepancies here. And for example, the ones that we have in yellow, the ovarian serous and the 2 rows from the top, where it had a bump above the positive LOH percentage call, 16% being the cutoff for LOH high and below 16 LOH low. And so this was called high at 16.2, and our HRD scores were 3. And the other one was the prostate adenocarcinoma, which had a high LOH at 19%, and our HRD call was low, 42 being our cutoff. But it just shows that there is a discrepancy in LOH and HRD, and that was echoed in a poster at last year's ASCO, identifying the fact that LOH and HRD don't have good concordance. And that makes sense because HRD scoring has so much more involved in determining an HRD deficiency beyond simple loss of heterozygosity. And I think that this table highlights that. If you look at our test performance of HRD calling versus percent LOH, you can see here that it has a non-impressive sensitivity at 60%. And so this was encouraging in that we had some concordance, but it wasn't where we felt it was adequate in terms of assessing a patient for the ability for PARP inhibitor indication. Still understanding that in the literature, there is these states of percent LOH and HRD may not be equal, and that HRD might be a better, more comprehensive assessment of true HRD status. So the next comparison we did was basically looking at apples to apples. Let's look at what true comprehensive looks at HRD deficiency and genomic scarring look like from a orthogonal view. So this is an outside laboratory that uses genomic instability scoring, and we took a small series of high-grade serous ovarian cancers and looked at the call for their genomic scarring, and we did our assessment of our HRD status, and found an encouraging result in that we were able to identify or mimic and correlate in this small series fairly well the status of HRD high and HRD low. This is our test performance here, basically showing that it was a good concordance study, but in a very small series, but encouraging in the fact that our solution to use NGS data using the BioDiscovery NX Clinical software bioinformatic pipeline is able to assess the status of HRD in a way that can reflect other laboratories that are doing this study. We also took a physiologic look at HRD, and we compared the chemotherapy response scores for ovarian high-grade serous cancers. And this is a score that is used to assess the cancer's sensitivity to taxane therapy. And so after surgical resection and with neoadjuvant therapy, followed by surgical excision, the tumor is assessed for its response to chemotherapy, almost an in vivo assessment of its ability to be sensitive to that particular chemotherapy. And when there is minimal response, it's given a CRS score of 1. When there's a significant response, it's given a CRS score of 3. In the literature, it's been noted that CRS3 serous ovarian cancers usually have some sort of HRD deficiency. And so in that physiologic state, we try to see if we can compare CRS3 scores and see if those scores could mimic a high HRD status based on our scoring. And what we found was discrepant in that there were a number of high-grade serous ovarian cancers that were CRS3 that we had an HRD low score for, and we were puzzled by that. But let's put that aside for a moment. I also want to point out that there are other situations here where there was a CRS score of 1, but yet we still had a HRD score that was high. Interestingly, this case is very interesting to me because it highlights the fact that there are other things that cause a homologous recombination deficiency state. And so this didn't have a BRCA1 and 2 germline mutation. It didn't have other genes that were associated with HRD deficiency. But what it did have was a null p53 phenotype, which is another indication where there's a homologous loss of p53 that is also a state that can cause genomic instability. And so in that mutation, this is the reason why it probably had a high HRD. Going back to the CRS3 scores where we had an HRD score that was low, this was very important and instructive for us to see because this showed that tumor percentage was a significant component to HRD scoring, and that when we had a lot of tumor to assess, we had very good HRD concordance. When tumor percentage dropped, that HRD concordance also dropped. And this was significant in a real world sense because if in the standard of care where neoadjuvant chemotherapy is given before surgical excision, oftentimes what happens is that a patient is diagnosed on a peritoneal fluid where there is small cells that are identified as having an ovarian phenotype, and that is the diagnosis of ovarian cancer. When that diagnosis is made, the patient is given neoadjuvant chemotherapy, and then surgical excision is done. And then in that surgical specimen, a lot of the tumor is gone for CRS3 scores. And in those situations, all we have from an NGS laboratory standpoint to work with is a small cytologic preparation with a few cells, and then a tumor that is pretty much completely destroyed by chemotherapy. So in those situations, there's no tissue available for an HRD assessment if that patient recurred to see if that patient is available for PARP inhibitor therapy. And in the next slide, that sensitivity to tumor percentage is highlighted here when we ran the same tumor, but then diluted that tumor percentage down from 80% down to 20%. And then Zan, why don't you talk us through these 4 panes here?
Sure. This is a data-heavy look at the 4 panes of, I'm thinking it's a chromosome 12 example. So what we see is in the upper left with 80%, we find our index clinical classifications highlighted in gold and in pink. And as we took the normal margin tissue from that patient's tumors and normal sample or resection sample, I should say, and diluted it out, we found that we lost the ability to detect what state changes were occurring after the first dilution scheme of 60%. So it does stack up with the ability to calculate the LR ratio that tells us whether things pass a threshold of being a state change or not. And there's more to extrapolate, I think, from understanding that and knowing the accurate expectation of where the sensitivity lies.
Yeah, I mean, that's something to highlight is that drop happened quite significantly and very early at 70 to 60%. So you can see how much of an impact that tumor percentage is for that HRD assessment. And so this is the reason why an in-house institutional-based assay is so important, because now we can work with our providers to say that I know that the diagnosis is going to be made on a cytologic preparation, but we may want to have a tissue source available such that if this patient does respond well to taxane therapy, CRS3 scoring, we have tissue available to assess for HRD on follow-up if there's a recurrence, to work with our clinicians to be able to provide us the specimens available to help them out with therapeutic options later on for this patient. And then lastly, Zan, you want to take us through this slide?
Sure. This is just to finally touch on what's down the, it's available and was down the pike while we were doing our research. Their NXClinical's most latest release is integrated to like automatically classify and take the genomic scar patterns to help us score and simplify our workflow. It covers when genomic scars are close together. So it's able to omit the small gaps from being counted to the rule that they need to be a certain 3 megabases apart. And it does a comprehensive way of evaluating aneuploidy and other mechanisms that will also be ruled out of calling homologous repair deficiency criteria that we didn't really touch on. And so ultimately the automation of this is available and makes this a really refined workflow to be able to take your NGS data while it's in the bioinformatic annotation pipeline and cooperatively allow the HRD calculations to be assessed on the tumor types of choice.
And then being able to use NXClinical both for NGS data and microarray data is also helpful. And so for NextSeq 550 users that are able to use both NGS data and also the Infinium chip, A50K chip, for assessment of HRD, this is going to be very helpful. So to overcome things like tumor percentage, we'll be looking at where is the drop off for tumor percentage based on microarray, and we expect it to be somewhere around 20%. So in this workflow would be, if we were not able to assess HRD by NGS, to be able to flip into microarray assessment of HRD, and then still using the same bioinformatic pipeline is going to be very helpful, to be able to report that data. We also look forward to maybe using and seeing if we can do this by optical genome mapping, which I'm sure that because BioNano and Biodiscovery both have that type of collaboration, was going to be very interesting to see how that data looks. Are there any questions? Thank you.